Welcome to our video on endometritis and pelvic inflammatory disease. Let's get started. Here's our overview slide. Let's begin by discussing endometritis. For each condition, we'll be discussing the definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. So let's begin with the definition of endometritis. Endometritis is defined as inflammation of the uterine endometrium. It's classified as acute and chronic. With regards to the pathophysiology, endometritis is caused by retained material in the uterus, which serves as a nidus for bacteria. It's most commonly caused by either chlamydia trachomatis or Neisseria gonorrhea, and rarely it may even be caused by Mycobacterium tuberculosis. As for the risk factors, endometritis can be due to retained products of conception after delivery. In this case, endometritis is commonly referred to as postpartum endometritis. It can also occur after spontaneous abortion or iatrogenic pregnancy termination. Finally, it can be caused by intrauterine devices, which can introduce bacteria into the uterus from the vagina. Okay, now let's discuss the clinical features. Fever is present almost exclusively in acute endometritis. In fact, the presence of fever is an important distinguishing factor between acute and chronic forms of endometritis, because both of them are usually characterized by abnormal uterine bleeding, pelvic pain, and uterine tenderness. Chronic endometritis may even be asymptomatic. This is the typical histological appearance of chronic endometritis. As you can see from the image, there are dispersed plasma cells, as well as neutrophils throughout the endometrium. Okay, moving on to diagnosis. The diagnosis of endometritis is mostly clinical, based on the findings of fever, uterine tenderness, and purulent vaginal discharge. A CBC and urine culture are ordered routinely to evaluate patients for infection. Endometrial biopsy with culture, as well as an acid fast stain, can potentially be performed. Chronic endometritis is usually characterized by plasma cells on biopsy, as we just saw. Additionally, menstrual blood culture can be done. In fact, menstrual blood culture is better than endometrial biopsy in detecting TB endometritis. It's worth mentioning that endometrial biopsy and menstrual blood culture are not routinely performed, and clinical findings are usually enough to make the diagnosis and initiate treatment. All right, moving on to treatment. Acute endometritis is treated with a combination of clindamycin and gentamicin with possible addition of ampicillin if there is vaginal colonization with group B strep. On the other hand, chronic endometritis is usually treated with doxycycline. All right, let's try a question. A 32-year-old female comes to the physician due to lower abdominal pain for the last 5 days. The pain is dull. She underwent spontaneous abortion 7 days ago. Her vital signs are significant for a temperature of 38.5 degrees Celsius. Lower abdominal palpation reveals uterine tenderness. Purulent cervical discharge is noted on colposcopy. What is the best choice of antimicrobial therapy for this patient? All right, this patient presents with lower abdominal pain, fever, and uterine tenderness starting after spontaneous abortion. Additionally, there is purulent cervical discharge on colposcopy. This combination of findings is most consistent with acute endometritis, and the treatment for this is clindamycin and gentamicin. Okay, now let's move on to discuss pelvic inflammatory disease, beginning again with the definition. Pelvic inflammatory disease, or PID, is defined as inflammation of the upper reproductive tract. Let's discuss the different components of PID and familiarize ourselves with the relevant terminology. Cervicitis, as the name implies, is inflammation of the cervix. Endometritis, as we just discussed, is inflammation of the endometrium. Salpingitis signifies inflamed fallopian tubes, while oophoritis refers to inflamed ovaries. Tubo-ovarian abscess is an inflammatory mass involving the fallopian tube and the ovary. We'll talk about this in another section. Finally, perihepatitis, or Fitzhugh-Curtis syndrome, is inflammation of the perihepatic capsule, also known as Gleason's capsule, and this is a highly tested association of PID. Okay, moving on to pathophysiology. PID is usually a polymicrobial infection of the organs that we just discussed. However, two main pathogens to keep in mind are chlamydia trachomatis or Neisseria gonorrhea, and chlamydia trachomatis is more common than Neisseria gonorrhea. Okay, let's talk about some risk factors. Multiple sexual partners and an inconsistent use of barrier contraception are the greatest risk factors for PID. If a woman has a prior history of PID, she is more likely to get the same infection in the future. Those ages 15 to 25 are at the greatest risk. Finally, if a woman's partner has a sexually transmitted infection, she's more likely to develop PID as well. Okay, moving on, now let's discuss the clinical features of PID. Fever greater than 38.3 degrees Celsius is one of the most common symptoms. Another characteristic finding is cervical motion tenderness. This is when a female experiences very severe abrupt pain when the cervix is palpated with a finger. This finding is sometimes referred to as a chandelier sign due to the abrupt nature of the pain. Constant pelvic pain is almost always present. Mucopurulent cervical discharge is commonly seen on colposcopy. Finally, if an infection spreads to the liver capsule via the peritoneum, the patient is then diagnosed with Fitzhugh-Curtis syndrome, which we briefly discussed earlier. And this condition is characterized by right upper quadrant pain and has pathognomonic violin string adhesions of the peritoneum to the liver. Here is a colposcopy image showing mucopurulent cervical discharge consistent with pelvic inflammatory disease. You can appreciate this whitish cervical discharge. This is a classic appearance of the violin string adhesions between the liver capsule and the peritoneum. And again, this is seen in Fitzhugh-Curtis syndrome. The diagnosis of PID is based on the combination of clinical symptoms described on the previous slides and a cervical nucleic acid amplification test, or NAT, which is specifically done for chlamydia and gonorrhea. Okay, moving on to treatment. Treatment can be broken down into outpatient and inpatient. For outpatient treatment, the regimen includes ceftriaxone and doxycycline to cover both gonorrhea and chlamydia. On the other hand, an inpatient antibiotic regimen consists of IV cefoxitin and doxycycline. An alternative inpatient regimen is the combination of IV gentamicin and clindamycin. There are several indications for hospitalization of the patient with PID. If a woman has failed outpatient treatment or she is pregnant, she needs to be hospitalized. Additionally, if the patient is unable to tolerate oral medications or she is non-compliant with outpatient therapy, she should also be admitted to the hospital. Finally, patients with a severe presentation, such as vomiting, a high fever, and other complications such as a tubo-ovarian abscess or perihepatitis should also be hospitalized. All right, let's wrap up with a final question. A 24-year-old female comes to the physician due to pelvic pain for the last week. She has recently noticed malodorous vaginal discharge. She had 6 sexual partners over the last 2 months, and she takes oral contraceptive pills. She has a temperature of 40 degrees Celsius. Colposcopy reveals an erythematous cervix with mucopurulent discharge. A cervical nucleic acid amplification test is performed. What is the main pathogen responsible for this patient's condition? This patient presents with pelvic pain, fever, and cervical mucopurulent discharge, and she also has multiple sexual partners. All of these clues are consistent with PID. Although PID is usually a polymicrobial infection, chlamydia is the most common pathogen responsible for the initial inflammation. So the answer to the question is chlamydia. And that concludes our lecture.